All right, welcome to today's Aspirational Healthcare Advisors meeting. We are joined today by Heidi Cottle and her teammate Ryan, and we're excited to hear about some very cool analytics tools that they've built. We've talked about them in the past. I think we've shared a little bit of information around them, but today we get into more of a deep dive and see what they've built. So I'm going to turn some time over to Heidi to introduce you and Ryan.
Okay. Well, like always, it's always a pleasure to be part of the Aspirational Healthcare team. Let me give you a little bit of background as to the impetus of kind of building these tools and what we're doing with the tools. So as all of us are aware on this call, the price transparency laws, which we've all been a party to, supportive of, etc., that similar to everybody that is on the aspirational healthcare group here, that, one of my, what I would consider North Stars has been, how do we transform healthcare and bring cost and quality accountability to the forefront of those decisions? And so that was the primary impetus for this. So was able to, get the support organizationally to be really a first mover in the healthcare transparency environment. So we essentially built two tools. One, and Ryan, I'll let Ryan introduce himself and we'll go into the tools. But we've really tried to build solutions to help crosswalk and minimize the disruption and use technology to assist in making this transition more smoothly for the market. So Ryan, why don't you introduce yourself and we'll get going.
Yeah, thank you, Heidi. It's an absolute pleasure and honor to be here in front of you all today and present a little bit about what we're up to. Ryan Bozrab, I'm on Heidi's team. I serve as our Vice President of Transparency and Clinical Risk Management. I reside in Indianapolis, Indiana. I've been a Hoosier my whole life. I've been in healthcare for about 14 years. I started my career as a clinician. I've got my clinical doctorate in physical therapy, certified in lifestyle medicine and preventive medicine, and did a lot of non-traditional approaches to self-care and well-being when I was a practicing clinician, and then had an opportunity to lead population health and well-being at a large health system in downtown Indianapolis called Eskenazi Health. Our mission is to serve the underserved population. And so did a lot within food deserts, prescriptions for healthy foods like 10 years ago. Vidar, I know Dr. Dexter Sherney really well. I know he's on your board for the food as medicine. So I got to collaborate with Dexter back in the day when he was at Cummins and some of the great work he was doing with the on-site clinic work there in Southern Indiana. And had some time in the consulting seat, consulting self-funded employers in Indiana, really bringing cost containment and analytics to really help drive solutions for them. And had a stint, Daryl, I think, out in your neck of the woods. I was leading product strategy and management for about 2 years at Artem employers. So I had a lot of work with, jumbo size employers as well as competitors to NFP and in market health plans of really bringing data and analytics solutions to meet their needs. And so really, today is really the big focus on how can we bring, through the Transparency and Coverage Act and the CAA really predicated on moving these price transparency initiatives forward. How can we bring together this data by overlaying Medicare data and quality as new intelligence for people to have a better business case to really move the dial on saving costs and improving outcomes in healthcare? So happy to be here today.
Great. So we'll go ahead and dive in. We've just got a couple of, this is definitely not death by PowerPoint. We've got a couple of slides just to kind of introduce how the product was built and designed. And then what we'd like to do is show you kind of the art of the possible within the data set. And so, Ryan, if you'll proceed, everybody here, just high level, knows who our organization is, but these are the points that we are solving for. And that is that inherently, what we're doing is we are, scraping the machine readable files from hospitals and from payers. Now, those two data sets in and of themselves are not actionable. So what we have done is that we have aggregated that information, and then we have put it in a data analytics engine. And you would assume that if I had procedure 470, which is a knee replacement, that what the hospital posted and what the payer posted for their negotiated rate with the hospital should match, right? Logically, we would think that. Unfortunately, when we allow the data to tell the story, that is in fact not the case. And so what we have done through our data lake is that we have brought in additional data sets, which we'll share with you, as Ryan inferred, both for quality as well as using benchmark proxy of CMS data, to be able to, bring some clarity to the data and make insights to action. So what really our primary objective was to help hospitals, because recognize that hospitals have been equally as much in the dark as we have, that this has been in that contract black box. And so from a commercial standpoint, they don't know where they competitively sit with other hospitals, nor ambulatory surgical centers, nor providers. Do they truly understand where their competitive positioning is in the market? So what we've done is we've built a tool both for the lens of the healthcare delivery system as well as the lens for the employer. And through those two lenses, TP Compare has been developed specifically to deliver to the healthcare delivery system, but we also have built a tool specifically for the employer and as the purchaser. So we want to be able to serve both markets and crosswalk them and start making them less of, hey, there's been a lot of finger pointing in our industry that it's the hospital's fault. No, it's the employer's fault. And essentially, we need to get those two stakeholders better aligned. And so we're seeing that within the hospital distribution channel, that they're really focused in two areas right now. They're struggling out of the pandemic, and finances are difficult. So they're struggling. Number one, there's a real race to ambulatory surgical. And then secondly, there's a real race to community-based health plans with direct to employer contracting. And so one of the ways in which we're creating this crosswalk is to get those two stakeholders at the table to start talking. So what these two tools do is that on the TP Compare side, that the TP Compare side really affords the hospitals now with this empirical data to do about, I would say, 5 different things. And the top 3 are the most critical to them. It's able to assist them in positioning to improve their market share, looking at their competitors, benchmarking, being able to see where they're at. 2, being able to use this empirical data to negotiate with payers. They've never seen where, what the pricing is differently between whether it's Aetna, Cigna, United, the Blues, narrow network, which now this transparency data allows them that information to be able to, come from a position of strength in their negotiating with the payers. The third being reducing expenses through technology aggregation. Most of the systems, especially the bigger hospital systems, are purchasing various data sets to be able to figure out and work back into different algorithms to try and, negotiate with the payers and find out where they're positioned in the market. Well, through what we have done in our data lake and aggregating these data sets, they can now basically, reduce their expenses through technology aggregation through our tool, which has been extremely helpful. And then the information from our tool then can also feed their revenue cycle management information to improve leakage and other things. So we've also, the fourth being that we've helped them to build new revenue streams that they haven't even considered in the market. And then really fifth, to help them develop strategies to align with their business objectives. The last one, which I kind of bring up as, okay, these are the 5 for the hospital focus. The last one really is to mitigate their domestic risk, which then crosses over to the purchaser side, because any hospital system wears the hat of both the healthcare deliverer as well as the employer. And so we're able to, through the tool that we've developed for employers, which is a claims repricing tool, which Ryan will walk through and show you, it helps mitigate their domestic plan risk, as you know, they have a fiduciary responsibility to develop a process for evaluating their own health plan. So we're able to do kind of a combination and bringing the value to the market in those 6 different ways. Excuse me, I'm going to sneeze. Oh, my apologies. Okay, so let me pause for a moment before we kind of get into how the tool works, how the data lake was built, and kind of walk through some different use cases. Any questions, comments, concerns?
I would like to see if anybody has any comments about, to me, creating transparency on both sides of the market creates market forces to drive quality and cost. To me, it's like the brilliance of doing both is how we reach true market forces. But I'd love to hear other people's thoughts.
Yeah, any comments?
Heidi, does this like either replace or complement the vendor management types of tools that a lot of hospitals are already using or looking at using?
Yes, it does.
Does it replace or complement either one?
It depends on how, and it's amazing to us because we've been talking to hundreds of different hospital systems that are either, a client of ours or a prospective client of ours, that the way that they have designed kind of their vendor management within their contract revenue department, that in their contract revenue department, that's where some of the technology aggregation we're able to help them achieve, because they have purchased other data sets, but they're also trying to, bring in, they're trying to compare data sets that aren't homogeneous. So you're comparing an apple with an orange, or, and so what this transparency data does, because it's providing a baseline of evaluation, it's allowed costs. So you have your, whatever your build cost is up here, the allowed cost or the negotiated cost then becomes a baseline for every party to be evaluated. So the answer is, it depends on how they build it, but most frequently they're saying, oh my gosh, this replaces what we're trying to do over here and back into a formula. Okay, because for example, the all payers claim database, that's based on paid claims, but then you've got benefit variables, right? And you're trying to figure out, well, with all the plan variables, what's the algorithm to normalize that? So we start with the normalized data set, which helps them in their own internal evaluation. But it really depends, Jeff, on how they built that infrastructure to evaluate it, whether we can fully replace or partially replace some of what they're doing.
So it gives them a chance to translate or move from this whole discount game that gets played, inflated prices and then a discount. It gives them a chance to show what they can do when they direct contract.
Yep. And because this data is real time, Jeff, which is key. So the all payers claim databases are normally in the rearview mirror 6 to 12 to 18 months. Okay, this is real time data.
Right.
And based on the cadences, the hospitals, right now it's about 84 to 87%, depending on where you look as to who's posted. And as you guys know, CMS is actively auditing about 200 hospital systems a month for compliance with the, Hospital Transparency Act. So there's a concerted effort to get hospitals compliant. So from that vantage point, that the real-time nature of this data, the payers, if they've negotiated changes, they have to post within 15 days. And so based on those cadences, we're really getting real-time data sets that, we can run monthly, quarterly, et cetera, to see what has been updated, to give kind of a real-time look into what cost of care is. Now, there's some definite improvements that are necessary, and we're working at a policy level to improve consistency in reporting. But I can tell you that it's significantly better than where we were.
That's great news.
Well, and
Yeah.
Heidi, maybe while we're kind of on the big picture, seems like you shared with me that even in the short period of time that we've had price transparency, what used to be all over the map when it came to prices, I mean, literally with no reasonability at all, there's already been a compression. Talk about that. Have you already seen that because now things are open, that more and more hospitals are starting to migrate their pricing into more of a compressed variance?
I would tell you some of our early observations. Okay. Number one, that cost and quality are not synonymous. And
Right.
Ryan's going to show you a couple of examples in a couple of markets where some of the higher cost procedures do not have the highest quality scoring. Okay. Secondly, in our observations, that we are also seeing that hospitals are increasing their cash rate because of reference-based pricing, and they don't want people to choose that lower cost option. And that we are seeing now the compression, we're seeing some hospitals, early adopters of this data, if they realize that their prices are so much lower than the market, they're bringing those prices up more in alignment or, competitive parity.
Yeah.
Brian, that's a key.
But what we're also seeing is the compression the other way, that some of the higher costs are coming down. So we're seeing kind of a balancing, to your point, Daryl, in that we're starting to see the objective of price transparency starting even in the early stages to come into place. So Ryan, let me turn some time over to you.
Can I just say, Heidi, just because you deserve it,
that
you can say you told me so. Remember a few months ago when we first started this conversation, you said that cash prices were going to go up.
Yeah.
And they have. So you're welcome to say you told me so.
Well, I don't like being right in these instances. Okay. Because I think part of this, it's not that we haven't had visibility, but because of the gag clauses, we've been restricted, and we are still fighting, as everybody knows on the call, we're still fighting with interpretations of what's public and what's not public with price transparency, but we're making a lot of headway. And this is one of the first tools. We're very familiar with our competitors out there, Daryl, and because we have decided to ingest, the petabytes of data, and anybody on the call who doesn't understand what a petabyte is, 1 petabyte is equal, if you made it into a digital song, it would take you 6 years to listen to. So most people looking at what the cost would be to ingest all this data, and we're actually past 2 petabytes now, that ingest all this data and then make it actionable is a pretty heavy lift. So most people have opted to do it regionally and to do a few variations, but we decided to eat the whole enchilada, and we're able to actually aggregate and make this data actionable. So, Ryan.
Cool.
Yeah, thank you, Heidi. I don't even know where to go from there. So
talk about the data lake, because we've kind of circled, several things.
Yeah, I'll get into maybe just to hit home, these two solutions. The use cases are, while there are overlap in regards to the employer and the hospital, the use cases are definitely different to a degree, but the data set that's driving the use cases are the same for the employer or the hospital. So first things first, we're scrubbing all of the payer data across the US. In the payer data, it's a lot more robust than what's in the hospital machine readable files. So in the payer data at a high level, we're getting negotiated rates, we're getting derived amounts, which can include bundling, fee schedules, per diems and percentages, which is not as pertinent from the employer space. From the hospital files, we're getting the negotiated rate, so you can verify by code what the hospital posted versus what the payer posted and vice versa, which is interesting. We're getting cash rates, and we're also getting list price from them as well. We're, from a benchmark perspective, we're bringing in Medicare adjusted rates, which is important, not the Medicare base rate that you can just pull offline. So we're bringing in the IPPS and the OPPS ratings, both from an inpatient and outpatient perspective. So it's the Medicare rates are risk adjusted by MSA, metropolitan service area. So that's key from like a true benchmark proxy to the allowed amounts. And then while access to the allowed amount of negotiated rate, once again, has been a black box forever, we've had access to billed amount, which is a somewhat of a Fugazi number, and then a paid amount. We now have access to, and while that's key, we also believe that, you know, that's one side of the coin. The other side of the coin is quality. So we've partnered with Quantros, who's been in the industry for about 20 years at this point. I'm sure most of you have all heard of them on the call. They were acquired by Healthcare Blue Book a couple of years ago. And we have the ability to get down all the way to the individual doc. But from a employer's level perspective, we can do inpatient, outpatient, surgical, non-surgical, and actually get down to service line. So outpatient or cardiology, orthopedics, urology, et cetera. So you can pretty much take like the DRGs or CPTs that fall underneath those buckets and kind of bring them underneath that quality score to give you kind of a high level how are quality ratings going. Now, I know we can also get down to individual doc, but just from a high level perspective for employer, it gives them a really good lens of what the heck's happening today within the landscape of where their employers are getting their care, especially with the variability that you can see within a PPO. So, you know, from a reporting capability perspective, it's pretty straightforward. We can get all the way down to MPI, which is super important. We can look at any CPT or DRG to be able to compare and contrast. We can look at by payer. We can look at by network name. So PPO, HMO, if there's a narrow network in play, like for instance, Surest through UHC, we can get rates on Surest as well to see if those rates are actually better than their PPO rates. And then be able to compare and contrast those rates across, you know, anybody you want to compare and contrast to within a given market. So from an output perspective of what this could look like. So like I said, I reside in Indianapolis. We have some of the best care in the entire US. We also have some of the most expensive care in Indiana. So this is for DRG 455, which is a spinal fusion code. We're looking at IU Health. They're one of the largest hospitals. I think they're top 10 or 12 hospitals in the US. They got about 30 hospitals. IU Health North and West, kind of the northwest side of Indianapolis. And then you've got St. Vincent's, which is part of Ascension. Riverview, which is a regional hospital that's within 15 minutes, 20 minutes-ish from any given one of these hospitals here. And then Ortho Indy, which is unique. While they're an ambulatory surgical center, they're also a small hospital that serves also as an ASC. So they're very unique. What we're providing here is what you're seeing here. Let's look at Anthem. So we're not delineating out by PPO or HMO here. We're just averaging out the network rate. And you can see, you know, that roughly $95,000 for Anthem for IU Health 2's facilities. Then you go to St. Vincent's Carmel, which is about $7,000 less-ish. And then you go down to Riverview, which is about half the cost of IU Health. And so people might say, well, is quality different? Well, then you go to the left there, and 0 being the worst, 1 being the best from a quality perspective. We're looking at unplanned encounters. We're looking at readmission rates to the hospital. I'm forgetting a few other things, but the high level, those are the main things that are driving the quality ratings. And you can see actually Riverview from just an overall perspective, their quality scores are better than IU Health. So as employers start to get their hands on this, you know, you'll go to the bottom left. You start thinking about, can we use this data to validate we're in the best network? Can we use this data to start thinking about narrow networks, really focusing on highest quality, lowest cost, and have a plan designed to support it from an in-network steerage perspective? And then obviously thinking about, you know, more direct contracting or maybe even reference-based pricing. So I always say, you know, the solutions per se haven't necessarily changed in regards to what are the things an employer can do. It's just this data provides a better business case that we've ever had before to actually hopefully move the dial to do something. So, and then you overlay that to the Medicare rate, and it can be, pretty significant difference when the employer starts to see this. And majority of folks I've talked to just never knew that this was going on, that these rates were that different. And that the quality, is that different as well, especially majority of what I've seen across the country. And I've looked at, I don't even know, over 30, 40 states at this given point in time of all this data. Majority of the hospitals that are the most expensive have the lowest quality ratings or not the best quality ratings in the market. So definitely the highest expense is definitely not driving better outcomes.
Well, and can I ask whether or not there's huge variation between departments within the hospital?
Yeah.
Because,
we can get, so Daryl, when Ryan jumps in there, that we can show you by, well, a couple of things. We can drill down to the providers, but we can also drill down to the specific categories, so cardiology, pulmonology, etc., and compare those quality scores specifically to the same data set. So we can do it on a high level, or we can deep dive into those details.
Because I would imagine there's a lot of variance. Just because you're a good hospital with cardiac doesn't mean you're a good orthopedic surgeon hospital.
No.
Yeah, and that's exactly. Can everybody see my screen here in regard to the you're seeing some bar graphs, some
we can
fun
see it.
colored bar graphs. Okay. So at a high level here, we're looking at roughly the same hospitals that we just looked at on the deck, on the slide. We're breaking it down. We're looking at surgical outpatient here, 2022. We're actively working towards pulling in 2023 as we speak. And so we'll just hit at a high level exactly what you said, Daryl. So in blue is cardiology. So blue, we're looking at 0 being the worst, 100 being the best. Community has about 6 locations in Indiana. So Community Hospital South is just on the south side of Indianapolis. They tout that they have the best cardiology in Indiana. They're within the central Indiana. So their quality score is 75 out of 100. It's better than IU Health's north location. Not as, it's a little bit less than their north or than their west location. Riverview, once again, regional smaller hospital out of all these on here, has the best rating. And St. Vincent's Carmel doesn't do a lot of cardiology scoring. So we can actually get down to case count. So, if there's a low N value as an example, maybe that's skewing the data. So we can actually get down to that as well to be able to see. But, St. Vincent's Carmel doesn't do a lot of heart surgeries or procedures. So I would expect that score to be low. But, this debunks potentially some of the things that you hear from a marketing perspective to really break through the noise of what's actually happening. And now let's flip over to orthopedics, right? So we just saw spine surgery, right? So remember, IU Health is the most expensive. So by far, almost double than Riverview. So community, we're looking at the purple bar graph here, is at 78. IU Health North, while they're really expensive, their actual quality for orthopedics is pretty good. So 95 and 97. However, Riverview is 99. So, if an employer can save $50,000 on one surgery, why would they not do that? So, and St. Vincent's Carmel is down to 74. So this is just at a high level. We could slice this by inpatient, non-surgical. We can actually get all the way down to individual provider. There are definitely member-facing solutions in the market that we've definitely partnered with to get this information in a member's hands. Think of this as more high-level reporting for an employer, but how this actually gets implemented and getting the cost and quality information down to a member's hands, is a different type of solution that you'd bring forth. But, but if the employer wanted to get all the way down to individual doctor level, within a hospital for some reason, we can do that as well.
Nice. Hey, Ryan, do you want to explain the enhancements that Quantros? So remember, the machine readable files, those are real-time data sets, okay? How they look at quality is actually a little bit in the rearview mirror. But Quantros, and everybody on the call is probably aware of this, CMS is updating their star ratings as well right now. So what Quantros does is Quantros uses HEDIS, which is a CMS, HEDIS scoring from their foundation, just like CMS does. And then they build upon that with a couple of different components to look at other attributes of quality. But I'm going to tell you, and this is probably, Vidar, something notable, which you probably already know, but there is a real race to being able to get better quality scoring methodologies in place.
Yeah, we need that.
Yeah, there's definitely startup, scale up companies that are definitely right now rethinking what quality means in regards to, majority of what we see in healthcare today from a quality perspective is process, not necessarily driven really by what you should be doing, all the things that you should be doing prior to cutting, and what are the best practices to support that. And, just like research, right? I love research. It really drives, but unfortunately, a lot of research that gets done sits on a shelf and doesn't get implemented. And so there are some companies that are taking what's been great, it's been done out there, and putting it in a process and developing a methodology to really measure what quality means by procedure. So by spinal surgeries, et cetera, to really get to that granularity. That's not for today. But at a high level, what Quantros is doing here is they're leveraging CMS data, and then they've added intelligence on top of that. One, they're basically bundling all of those codes within the CMS data into major practice categories. That's how you're able to see cardiology, orthopedics, et cetera. And then they're risk adjusting the data using demographics and comorbidities. So from a quality score, like I said, we're looking at mortality, complications, and unplanned encounters. What they've also done, like I said, is risk adjusting that data. So for instance, let's say a hospital is in an affluent area treating a diabetic population. It's not necessarily fair to measure the quality ratings of a hospital in an affluent area versus a hospital that's treating a non-influent patient population, like in an inner city, that has a lot more social determinants of health factors that are limiting their care. It's kind of an apples to oranges comparison when you think about quality, just purely by the patient population. Right. So what Quantros has done is what they call their efficiency score. So it takes into account and risk adjusts age, gender, comorbidities, and billing practices within those given MSA areas to have a better apples to apples comparison. So majority of the scores drop, by the way, when you look at just efficiency score versus quality score. And then value score is basically an average between quality and efficiency. So what I just shared today is quality, but we can definitely take it a step further and do a more apples to apples risk adjusted comparison, which I think is really key. So, CMS kind of star ratings at a high level, this is in a lot deeper methodology than what you would see at Medicare.
Yeah, so within our data sets, we're able to, and Ryan's going to show you this, that we're able to query things. We do dashboards at a high level, but then we're able to drill down into some of those components, Daryl, that you're asking about. Hey, can I get down into an individual provider level? Can I get into these type of data sets? And so the way we look at advanced, and this is advanced data analytics, is the way we look at it is that, okay, you want data to tell the story, to drive decisions and drive, that cost and quality accountability. But we also want data to be our safety net, meaning for performance, outcomes, et cetera, to be able to say, okay, was our hypothesis accurate in all of these areas? And so from the employer lens, that's where, and Ryan's just going to stay on the hospital side, but crosswalking it to the employer lens, then we can ingest all the claims data and make it then very specific to a specific set of employees, members, et cetera. We're able to do that crosswalk as well. Okay.
Can I just add a little anecdote message here? So as a hospital administrator, and even Dr. Danish Gary just last week at our Aspirational Care Providers meeting talked about as a medical director for a major hospital, which we all know, as he went to administration to report on his department, the information was all about are we getting enough services to produce enough revenue?
Yeah.
That's what healthcare has been. How do we fill the beds and how do we get all the revenue? In my mind, as I look at this, I see a vision in the future where literally a hospital, because they're now being held accountable, this is what they're looking at. And when those department heads come to that administration meeting, what they're looking at is, why isn't our quality and cost better than our competition? Imagine the impact that'll have on the industry when this kind of data drives a hospital versus you're not getting enough stints put in.
Right. And because of CAA, I think it's going to take some time, Daryl. Employers are also going to push that as well, in that the messaging out to the market is going to be, okay, why are your quality scores not as good? Okay, if you're in our in-network or you're in our narrow network, why?
Mm-hmm.
Why were you selected? And there's going to be an interesting dialogue that ensues in all these areas.
So true.
Okay. Go ahead, Ryan.
So this, at a high level here, we're looking at the tool itself, and the art of the possible here is endless. So we'll just get into how you can filter. So at a high level, the two main sources driving the output are CPTs and DRGs from a coding perspective. So, we have the procedure code. Most people don't remember what the 5-digit codes are. So we can bring in the description of what that code is from a report perspective. Same thing from an inpatient perspective. We can look at the MSDRG and the description of that code. So those are the two main codes really driving the output.
Can I ask a question on that?
Yeah.
So I think Heidi and I have talked about this before. There's the CPT1 codes and the CPT2 codes, which include the HCPCS code. So CPT1 is sort of that overall procedure that often hospitals use to estimate at the beginning, but the CPT2 is what gets billed. Are you able to look at both of those and compare those?
We are. This is where we are, but we don't have the difference yet. Those are some of the legislative changes. We can see it, but it's the interpretation that we're limited by right now. Okay, that because of the inconsistency in how they're posting, that, for example, let's just use actually a DRG for maternity. Some hospitals include the baby in the nursery, some don't. Okay, so is that the reason why their posting is different than what the payer is, et cetera? So there's some interpretation, those insights to action to say, okay, these are the additional questions you have to ask, because the data set doesn't tell us yet.
Makes sense.
We can see it, but we have limitations on how we interpret that.
Yeah, what the why is.
Okay. Yeah. Okay. But that's some of the 4 of the pieces of legislation that passed the House and that are in the Senate. 2 of those would help immensely. Okay. And we just haven't seen final movement there yet. Okay.
From a provider level perspective, we can find them pretty much any way possible. I think what's most important is we can get all the way down to NPI to be able to find a provider. That's kind of the social security number for a provider. From, the sources in which we're bringing in, like I said, we can bring in both hospital and payer data. So you can choose one or both, or one or the other. From a payer detail perspective, we're bringing in the payer name, so Anthem, the Blues, or more than that, because we do definitely have more than just the BUCAs. And then, we can bring in by network name, which is key. So we can also bring in by PPO, HMO, et cetera, and I'll show that today. And then from a rate detail perspective, our solution today is really strong on institutional billing. We do have professional codes. It just wasn't, as a big need first going to market with this. We're getting more requests for professional data. And so our data with professional data more than it is now by the end of this quarter and going into Q1. So like I said, we do have access to professional data today. It just hasn't been a request, but we're starting to get more of that. So we're prioritizing bringing in more professional fees. going in through end of this year and through end of Q1 next year. From a rate type perspective, like I said, we can bring in negotiated rates, which is the main data set people are looking at, but payers are also posting what they call their derived rate. So that could include bundling. So as an example, maybe the difference is like a $7,000 difference between what the hospital posted and what the payer posted. But you can see if it's negotiated or derived. If it's derived, it includes bundling. Unfortunately, I can't tell you what's included in that $7,000 difference. So I can't tell you if it's like anesthesia and therapy and the baby is not included or included if it's a delivery code. But we can at least tell you the difference. Now, to Heidi's point, there is proposed legislations to provide more detail around that from just like a notes perspective, but none of that has been approved yet. But we can at least get down to the difference right now. So what I'm sharing here, there's so many use cases, but we're just kind of sticking to the theme of Indiana here. So Anthem's got their headquarters in downtown Indianapolis, one of them. So Anthem's got a big presence here, as well as UHC. We're looking at DRG 470, which is total knee, total hip from an inpatient perspective. We're looking at what the hospitals themselves posted. So I'm not looking at what the payers posted. By a handful of those hospitals we keep looking at. So IU Health West and North, Riverview, and St. Vincent's Carmel. I'm going to hit run. And so we're roughly at around 200 billion rows of data within a matter of seconds. We were able to query this data. So, we're looking at provider name. We're bringing an MPI here. We're looking at the description of the DRG. So like I mentioned, major, total knee, total hip, the rate source. This can be customized by any way somebody wants to look at this. And from a 470 perspective, the same thing holds true. IU Health West is the most expensive, North and West. You got St. Vincent's Carmel and then Riverview at about $18,000 difference, even though their quality scores are better from an orthopedic perspective. We're also comparing this as a benchmark proxy to the Medicare adjusted rate. That's why these rates are not identical, because there's a slight nuance between where these hospitals are from a metropolitan service area zip code perspective. So that's why there's a little bit difference. And so we can get down.
Can I have you pause, Ryan, just for a second?
Yeah.
So take a look at this, and Ryan can also bring in the quality scores real quickly, but let's take a look at Riverview for a moment. So their Medicare rate is 14,000, okay, where the Anthem rate, and he's running something else, that the Anthem rate was lower than IU Health. And yet IU Health was 13,000 some odd dollars. That 14,000 tell us they have more complex cases. Okay, because that dollar volume, the only reason why in a Medicare environment that you would see an increase is the adjusted rate, and the adjusted rate is only based on complexity. So by bringing in that benchmark proxy, we're able to then normalize the data set even with that information. And so with clients, we're also then able to bring in claims data and, additional, benchmarking type of data to then validate or dispute, like for performance guarantees, all those things. But there's so many, to Ryan's point, there's so many use cases here: clinical care navigation, coaching, the way we've designed our tool, and we'll talk a little bit about how we've monetized it, that, but there's so many use cases with this data set to help from the multiple different lenses that we see clients using it in multiple different ways.
Well, and is the basic search functionality the same between TP Compare and TPNet?
Yep.
So it doesn't matter whether I'm a navigator or whether I'm a hospital administrator, I'm basically able to sort through the data similarly.
Yep.
Yeah.
But what we've done is on the employer side, we've done a network of claims repricing. And, if we have time, we'll show you a couple of the pages of that. It's a 14-page report. So we've customized some reports to be able to do that as well.
And so what I did here, can everybody see my Excel document where there's like highlighted rows at top? Can we all see that?
Yep.
So what I did was, what we were seeing before by IU Health was that aggregated rate by Anthem. So what we were able to do is now we're pulling down by HMO, PPO, and traditional. So traditional is more of that national blue card for Anthem. So it's, the vast network throughout 50 states, even though the rates are different, with how they set them, but it's the access to the providers with nationally. So you'd expect that rate to be higher, but we can get down to that type of granularity. As you can see, you know, traditional is the most expensive, then PPO at 42.6, and then about $3,000 less is HMO. So, you know, we can get down to that. Now, the nuance to this and where, you know, we add a layer of consulting to this. When we work with hospitals, we do not just turn this over to them right now. It's too complicated. They don't have the training to even do this. And so we work as an adjunct basically to their team. So we work as an extension to their team. We basically work with them to define who they want to compare themselves against in the market. What are the payers they want to start with? Let's look at your charge master. And we can rock and roll. We've just did about I don't even know, what is it, Heidi, like 4,000 codes for a hospital that was looking to bump it up against their charge master. And we did it across.
We consolidated. Ryan's being kind. We consolidated 45,000 codes to that lesser
The 4,000.
Yeah. So, I mean, the type of granularity, I don't know if you guys can you, if I'm pulling this over, can you see this new screen or not?
Yeah, we can.
Yeah. So I kept it fall festive colors, orange and green, but this is actually within the Lehigh Valley area. We're looking at, you know, specifically they're looking to grow, on a hospital we're working with is looking to grow. So they're wanting to know, you know, what are the rates as they think of setting rates in a new market that they're not in. So ideally they want to look at PPO as like that benchmark proxy. So this is just DRGs alone based on their charge master. But we did it across, you know, Aetna, Cigna. We actually pulled in BCBS's high performance network rate, which is a key benchmark for them. The Independence Blues, UPMC, since this is in Pennsylvania, and United. And then we also brought in Medicare as a benchmark proxy. So we averaged out the codes based on how they do their charge master. And then if they want to get down by code level, they can as well. And then we also did a massive one on CPTs. Same story. So it's that type of granularity when we say when we work in collaboration with the hospital, that's how we would do it. From an employer's lens perspective, it's a little bit different in regards to, you know, we do have a report and we just don't have time today that can spit out a second opinion network reprice. But, you know, as they get access to their claims, we can also see, you know, maybe there's 3, 4, or 5 hospitals that are driving the highest utilization based on where members are. You know, if we can just simply pull 10 to 20 codes, the top codes that are driving within that hospital, and we can compare hospitals' rates, you know, to different payers and to different hospitals in the market, you know, it's a way to see maybe which some hospitals are driving the highest cost, and how you overlay quality as a part of that. Then it starts to have more of that conversation around, well, what are you going to do from a cost containment perspective? So same granularity that you're looking at here of what we can do for an employer too, just the use case from a, you know, benefits perspective is going to be a little bit different.
Well, and with, I know we only have 10 more minutes, but I want to make sure that we connect this with the easy button, the super build, and how within that innovative plan design, the navigator has access to the TP compare, and maybe talk a little bit about, you know, how this is facilitating, because the broker and the employer are like, just give me a really good plan that maximizes this. Talk a little bit maybe about how the navigator is going to use this to literally route people or direct people where, again, no cost, as long as you go where you're, you know, where you're being directed. Talk a little bit about how this fits within that super build.
Yeah. So Ryan, do you want to show the outcomes down below on this specific illustration? So essentially through the clinical care navigation, that the clinical care navigator will be able to see where the employees, you know, what their benefit design is, et cetera, and be able to guide them to right care, right time, right provider. But it's with a value-based plan design. So that's why we designed within the super build that tier 1 is that we waive the deductible for the member, right? So that we align the incentives in the plan design with cost and quality, okay? And then from that basis, we're actually protecting the employer's fiduciary risk.
Right.
In that we've developed a process for evaluation that includes both cost and quality in that determination, but really then helping bridge kind of the healthcare literacy side for employees. Okay, we're smart people. We've just never had access to this data.
Right.
So how do we navigate it quickly? Well, that's where we take, Daryl, coaching and clinical care navigation to educate the member as to what their choices are, still allow them their option, but now they have that cost and quality lens that they can see through to make those well-informed decisions before they have a procedure done. Okay, and again, you guys know this, non-emergency situations, right? But for those that you can plan, that's how we use it. Okay?
Well, and can you speak to, just again within the super build, let's say that navigator identifies with all this wonderful data that the best provider at the best rate isn't in the standard network. Can they still negotiate with that provider?
They can.
So that they can take advantage of the best.
They can.
Nice.
They can. So there's that latitude within the construct of what we built with Lee and the team on the super build to be able to cross all of those things. Okay. So let me just kind of in the last few minutes and open up for questions. That how we monetize the TP Compare, it's called TP Compare for the hospital, TP Net for the employer side. That within the super build, TP Net is already a part of that, what's baked into the super build. So if anybody uses the super build, you'll already have the TP Net available to you. Okay. Within the hospital systems, though, that the hospital systems, because we're kind of separating out on the TP Compare, if hospitals want to utilize this, it's kind of a SaaS/consulting hybrid model, that the cost for a hospital system essentially is lower than they can buy an all-payer claims database with all those data sets. So we've made it very cost effective for early adopters. And if people want to refer us into those hospitals, we can, do a revenue share and get some compensation if you want to be a part of that. We do all the heavy lifting with our team. But no, there's about 6,200 hospitals across the country. So we're barely, scraping the tip of the iceberg. And so it's a great opportunity if you're trying to set up high performance networks, hospital systems, et cetera. It's a great tool to be able to effectively do that. And so we can sell literally the TP Compare, the TP Net product, if people want to use that separately, and we can go through, as Ryan said, a little bit different demo on the claims repricing tool, and then you can sell it within the super build. So we've tried to accommodate the needs of the market in that easy button under the super build. Okay, but you can modularize it within the other frameworks as well.
So if Mark Holland is building a plan for an employer, and he's already got a lot of those pieces in place and doesn't want to jump over to the super build, he can still bring TP Net.
Yeah, he can.
Into that solution.
Yeah. Or if Mark had enough time before the renewal, could call us and say, hey, can I get some of my solutions in the super build so that I can make it turnkey?
Yeah.
We are happy to do that.
Just bolt those on.
Okay. So we'd love to get your input real quick, everybody. I know we always have just a couple of minutes because there's so much data to cover.
Question.
Has this been helpful?
I think things like this are going to transform healthcare. It's going to create for the first time true market forces, but you know how I feel. What are other comments? We have a few people still. Troy, Mark, Bidar, any comments or questions as we wrap this up?
I've got one. So have you guys found, because I've looked at the Quantros data, or I'm kind of a data nerd, so I've looked at all the data you showed in pieces. And so something I run into is sometimes the hospitals report as a group versus individual. Do y'all find that as well?
We're able to get down to the individual because what Ryan stated on the National Provider Identifier, the NPI level, because they have to post at the NPI level, we can get both the hospital and the provider now.
So I suspect that it's because I'm looking at the tools independently. So like Quantros in my area,
They aggregate it.
They aggregate it.
Yeah. So what we do, and that's why we decided to ingest the data independently and then aggregate it, is that if you don't do it that way, then you don't get to the granular detail. Yeah, great observation, Mark. Okay.
Anybody else? We got 1 more minute.
What kind of timeline should we expect for integrating, one of our specialty sort of pieces into this that you could add as Mark is thinking about adding some of his own? And would those specialty arrangements necessarily be part of tier 1 as opposed to tier 2 or tier 3?
Yeah. The answer to that, Jeff, I can't be as specific as you want me to be, because it's all contingent upon the contracting process with Lee's team and the specialty group, but he can normally turn it around very quickly. It's going to be that the contract that delays it. We can literally implement it within, 30 days, as long as there's already an API interface, because of how we've, made it modular and being able to interface things. So, 30, 60 days is really kind of the time frame right now.
Okay. That's good. All right.
Yeah.
Well, thanks, everybody. Thank you, Heidi. Thank you,
Yeah.
Ryan. I think this is pretty fantastic. We've got this recorded. We'll be putting it up on the Aspirational Healthcare Advisors page, so any of our advisors can access it. And again, just thank you so much for your time, and good job.
Yeah, well, thank you. And if you guys want to see the claims repricing report a little bit further, reach out and we'll schedule a separate time. Okay?
Okay.
All right. Sounds great.
Definitely
Have a
do
great
that.
weekend.
Have a
Thank
good
And any
weekend.
veterans, thank you for your service.
Yes, thanks.
All
for being
right.
with us.
Have a great day. Bye.